Very happy, whether it's a coincidence that we are having this session on Mother's Day. Obviously, it's only a mother who can breastfeed her child. And my sincere thanks to Team Neocon. Special thanks to Dr. Prashant Gowda and Dr. Dinkar, who have been at my neck almost on a weekly basis. So thank you. Let's get started. The first and foremost thing I want to share with you is the theme of the World Breastfeeding Week 2020. It says support breastfeeding for a healthier planet. So we have just one planet, and that planet needs all our support. And whenever we talk about breastfeeding, it is not a one-time event, like Prashant was saying. There is enormous things that we can share, and each patient is different whenever it comes to breastfeeding. I don't have one fit for all patients. And when we talk about breastfeeding education, we have so many things that comes in. And the last one I want all of you to focus is counseling on infant feeding options. And we had it in HIV, and now we have it in the COVID pandemic. Mothers will be needing more and more of our positive spirits to support them. What are the facts? Breastfeeding has universalized mankind. The milk in the mother's breast in India is similar to the milk in an American woman, just like the COVID has universalized the planet. But however, I must confess, there's a big lacunae in training and in practice in health workers. Any breastfeeding talks or workshops we have in conferences, I must confess, there is hardly any attendance. And as far as the promotion is concerned, there's a big nexus between between the infant formula lobby and the healthcare workers. So there's a big business between the breast and the baby. And now we're going for what is called as green feeding, though the mother does not get influenced by the manufacturers of the baby food industry. And of course, there's lots of politics in breastfeeding. We need to protect, promote, and support breastfeeding in all situations. So what is happening? If you look at the rates, exclusive breastfeeding is only 55%. Breastfeeding within 1 hour of birth, which is the most crucial, is 41%. And if you look at the birth cohort in India, we have 27 million babies born per year, and 13 million babies are on formula feed within the first 1 hour. And 14 million babies, some feeding is happening, but it's a very bad state of affairs. What happens to mothers when they don't breastfeed? I just want you to look at the screen because I have lots of things to share instead of going one by one. And most of you know what it is all about. And what is the target for India for 2025 from the present 55% to 65.7%? In 10 years, we will be able to increase only by 10% because it is a continuous process and it needs a lot of support. I know all of you know about the structure of the breast. Very often, I get a lot of references saying that the mother doesn't have a nipple. Nipple has nothing to do with breastfeeding. It is just an outlet. It's a big bite of the breast tissue that is required. And recent advances, we were wondering what is the role of this Montgomery glands. This Montgomery glands are the perfume of the breast and the lubricator of the breast. And we'll go further. We have the milk producing reflex, and we all know about it. So for the milk production, the baby has to suck at the breast should be in the right attachment. Only then the whole process starts in. And the milk ejection reflex. We have two very interesting hormones. I just wanted to share why do we hug and the importance of hug in a baby and the mother, because every time we are hugging, we will be interscapular space. That is where the oxytocin receptors are situated, and lots of oxytocin would be stimulated both in the mother and the baby. So the technique of holding is so important that we stimulate the oxytocin reflex. And also, as far as swallowing reflex is concerned, there are three important reflexes in breastfeeding: the rooting, the sucking, and the swallowing reflex. So when the swallowing reflex is as early as 12 weeks of intrauterine life, the sucking reflex is at 24 weeks, and the rooting reflex is 28 weeks. We have to capitalize on this innate reflexes. And also, the mother should know how to put the baby to the breast. When the breast is put into the baby's mouth, the nipple should aim at the roof of the palate, because the moment it aims at the roof of the palate, it stimulates the sucking reflex, and the baby sucks. And when the baby sucks, the milk drops go on the posterior part of the pharynx, and it goes inside, and baby learns to swallow. And when a mother stands in front of the mirror and looks at her nipple, they're pointing outwards and upwards. So as when the baby is put in, the nipple is directed towards the soft palate. Breast milk, all the advantages, we all know about it. And all the more during the COVID epidemic. That will be my last slide, because we still do not have clear-cut guidelines on that. So human milk is specifically adapted to the needs of the newborn. And we know that there is the immature immune system. Production is by unique bioactive factors. Presently, there are 121 bioactive factors listed, and the perinatal clinics of North, the whole issue on breastfeeding and preterm babies. And colostrum is a welcome drink for the newborn. Introduction of colostrum is the key in postnatal intestinal development. It's liquid gold in the golden hour. Colostrum cannot be seen, and it cannot be sucked. That is why we have a lot of issues when it comes to breastfeeding. To the screen, I can't, not. Okay. Very interesting. We have two hormones. We have estrogen and progesterone, where the breast was used to estrogen and progesterone for 9 full months, and subsequently is the prolactin and oxytocin. So there's a lot of competition. Yes, there's a lot of competition. We say hormones at war and hormones at harmony. By the time the estrogen goes out of the mother's system, it takes around 5 to 7 days. Therefore, the so-called retracted nipples become protractile after the 7 days. So that is why you cannot see the breast milk in the first few days. It doesn't even, it has to be sucked by the powerful sucking reflex of the newborn, which is about, I'm talking about the full term, 150 centimeters of water pressure. So we have to allow the hormones to gradually get out of the system and allow the lactation hormones, prolactin and oxytocin, to work. Breastfeeding is a confidence trick. It involves a lot of counseling skills. This particular photograph is that of a woman who was a victim of a dowry harassment. And just before her delivery, her husband had poured kerosene on her. And she was one of my patients from one of the government industries. And so much she had heard about my talk on breastfeeding. And she said, it does not matter, doctor. I protected my breasts when even the kerosene was being thrown. And she was able to breastfeed her child. And presently she and her child have settled down in UK. So what worked here? It was a counseling. So there have to be timely counseling. And there are counseling sessions 5 times. And now in the COVID situation, we may have to have many more counseling sessions for these mothers. We all know about colostrum. And in the first 48 hours, colostrum is sufficient food for the baby, because I'll just go over the various stomach sizes. This is a stomach size of the baby over day 3, day 1 week and 1 month. At birth, the size of the newborn stomach is just 20 ml. Whatever few drops the baby is getting in the first 24 hours of life is sufficient food and nutrition for the baby. So we know about the benefits of colostrum. I would just like to highlight that a term baby has 1 gram of meconium. The moment this baby is fed with colostrum, the clearing of the meconium is so rapid, it prevents jaundice, whatever pathological, it prevents jaundice in the newborn. It clears off the meconium, because we know each gram of milligram will lead to 1 milligram of bilirubin. So there is a variations in the composition of breast milk. So breast milk works as an appetizer, as a pacifier, and also as a dessert. So that way, each feed the milk varies, and we have fore milk and hind milk. Whenever we have a baby who is born premature, you get more of the hind milk so that the baby can put on rapid weight gain. Then we have breast milk contains lot of essential acids, and not only that, along with that, it is a package. We get lipase, which digests those fatty acids, but unfortunately, that scenario does not happen in animal milk or with a dairy milk. So anti-infective proteins are innumerable anti-infective proteins. Of late, we know that it contains HMO, human mono-oligosaccharides. The moment the baby takes this, it prevents the adherence of the organisms into the gut, especially in the current scenario. So iron in milk, we have sufficient. So preterm babies, I was saying that the protein content of the preterm mother's breast milk is much more than the preterm protein content of a full-term baby. So the full-term baby, it is 3 grams. A preterm baby, it will be 3.5 grams, so that it will help the baby to put on weight. And this is a wonderful study that was done by Bombay et al. Even 0.5 ml per kg of maternal breast milk in the first hours of birth paints the gut lifelong, and it makes it impervious. This is one of the wonderful experiences I had in Indira Gandhi. This is a 440-gram baby who was exclusively breastfed and did very well on that. So breastfeeding and low birth weight babies, all of you are neonatologists, you know that it prevents hypothermia, hypoglycemia, etc. And it reduces mortality. And breastfeeding within 1 hour, lots and lots of research is coming in that breastfeeding within 1 hour of birth is very, very crucial. Because in the woman, when she's pregnant, there will be hyperpigmentation of the nipple and areola. The distance between the umbilical from the vagina to the breast is 18 inches long. Therefore, the umbilical cord is 18 inches long. As soon as the baby is born, even before the umbilical cord is cut, and when the baby is put between the chest of the mother, the baby moves towards the nipple, and the mother's breast temperature, lactating mother's breast temperature, is 38 degrees centigrade, that of the amniotic fluid. The Montgomery gland secretions, and you won't believe it, the breast becomes areola becomes bulbar so that the baby can easily latch on. The moment the baby latches on, there is a high catecholamine surge in the newborn baby as is walking in the womb of the mother, and that catecholamine surge makes him very active. Once he starts sucking at the breast, then the oxytocin will be released and placenta will be expelled, preventing postpartum bleeding. Breastfeeding should be unrestricted. We have 8 to 12 times per day for 24 hours for the initial 6 weeks. Subsequently, the mother-infant dyad will adjust. Hence, they are called as a nursing couple. Most important to emphasize is breast milk should be removed either by the baby, manual expression. I recommend manual expression. You should never stain the breast beyond 3 hours because it starts suppression. It is called as feedback inhibitor of lactation. And the golden rule is how many times a child passes urine. Initial weight loss should be more than 88% of birth weight in the first 3-4 days, and it will return to birth weight in 7 to 10 days, which coincides with the mother's milk coming in full bloom. Like I said, the oxytocin and prolactin has taken over from estrogen and progesterone. And the weekly weight gain is 125 grams per week. So the urine output, I keep telling my students, it is 6 times after 6 days up to 6 weeks. Subsequently, it is a weight gain that should be emphasized for these babies. Very interesting article has come out in Octa Pediatrica 2019. The most important is the prenatal development of the flavor. So the food, the food the mother eats flavors the amniotic fluid. The amniotic fluid helps development of the olfactory bulb. The fetus drinks the amniotic fluid, develops preferences for the taste of the amniotic fluid, which is stimulated by the maternal breast odor, transmits taste by hand, breast, mouth movements, and licks the areola, starts suckling, and recognizes the taste in the breast milk and is rewarded by the family taste. So will be facilitated by the experience of the maternal and family flavors. Elderly are attracted to flavors of their childhood. So the golden hour, critical hour, I just now, again a repetition, hyperpigmentation, catecholamine surge, length of the umbilical cord, oxytocin, uterine contraction, skin to skin contact, warmth and useful commensals, thermoregulation. I just now told you temperature of the lactating breast is 38 degrees centigrade, like the uterus, the temperature of the uterine amniotic fluid. There's a development of the brain myelination, neuronal harmonization. 5 special senses are stimulated. Sucking reflex is 100 to 150 centimeters in the first hour of birth. We have to capitalize on that, so that it needs that strong suck to pull out the pre-colostrum plug and then the colostrum and subsequent mature milk flow. So there are various stages in the skin to skin contact, the first hour of birth. These are called as newborn instinctive stages, from birth cry to suckling stage and sleeping stage. So important to put the baby on the mother's breast. And this is the various stages of the baby. When the baby is put in the mother's breast, skin to skin contact on her chest within 1 hour of delivery. This is the usual Manivilas rounds, lactation rounds I used to do, where we used to ensure that the baby was put on the mother's chest, and breastfeeding was initiated. So now the latest guided 10 steps to successful breastfeeding 2018 step 4 states facilitate immediate and uninterrupted skin to skin contact for mothers to initiate breastfeeding as soon as possible after birth, especially after we have understood the newborn infant self-attached stages. Very crucial to put the baby to breast at night. There are many health workers who have been telling the mother, do not feed at night because the child may aspirate. Also instructed to sit up and feed. Do not worry when the baby is more than 1.8 kgs, because night feeding is very important, because there's a high surge of prolactin. It also suppresses the ovaries and facilitates the mother to relax. And we should not be worrying about, night feeding is very essential for sustaining breastfeeding. This not enough milk syndrome is a universal phenomenon, and all of us need to address this on a one-to-one basis. Remember always that the average Indian woman produces 240 liters of milk during the first 2 years of her life. So we all know how to put the baby to the breast. The most important thing is the chin of the baby should touch the breast. I have a global person called Mimi Masa who's just worked on this. She says chin should touch the breast and rest will happen automatically. People try to put the hand like this, or people try to just push only the nipple, and those kind of things happen. And this is always bring the baby to the breast and not breast to the baby. So correct position, the head and neck of the baby is in the straight line, chest of the baby touches chest of the mother, abdomen of the baby touches abdomen of the mother. So we know all you have to do is just lift the breast and tickle the upper lip of the baby. Child opens the mouth and take in close, ensuring that your hands are between the interscapular space, which is the stimulation of the oxytocin. This is the pattern of weight gain, because many people keep on getting worried. I had the baby gained weight now. There's not much weight gain at 8 months. Birth weight doubles on the thumb rule, doubles at 6 months, triples at 1 year, and quadruples at 2 years. So this is just a pattern of weight gain. And all of you must remember that there are growth spurts which happen at 3 weeks, 6 weeks, and 3 months. A very well settled baby suddenly seems to be acting very erratic. This is because of the growth spurts. It is a high demand baby. Now the baby is growing very rapidly and he needs more milk, and he and his mother self-regulate their need for milk. So he is demanding more. There is more milk. We say more milk you want, more sucking in the right technique. And these are times when many health workers feel that the mother doesn't have enough milk and get into other situations. So even in the COVID situation, breastfeed with all the precautions, and cesarean section babies. And whenever a mother is sick, helping a sick mother to breastfeed, just because the mother has some infection, you should not tell her you stop breastfeeding, because there's a fascinating phenomenon called homing phenomenon. Whatever infection the mother suffers from, she secretes the antibodies against that. Antibodies reach the baby through her breast milk. So even if you have a sick baby, if you can directly breastfeed, do that. If you cannot, cup feeding, tube feeding, ensure that all sick babies are breastfed. There's another important thing, that calories required well-to-do women need not take extra calories. It's only the poor women where we say one extra meal which contains 500 calories. So breast milk is also a major supplier of nutrition even in the second year of life. 40% of the caloric needs are provided by breastfeeding in the second year of life. And for breastfeeding mothers in disasters, breastfeeding protects babies. Stress will not dry up your milk, will not spoil your milk. Breastfeed more often because we are going through a lot of stress. More milk and comfort the baby. When without power, hand express and keep feeding your baby, because this particular organization believes in breast pumps, but I believe more in manual expression, and keep on breastfeeding. Recently, we raised, Dr. Arun Gupta raised an objection because relief materials had a lot of tinned milk in it. So we should not be going into that. And as far as the obstetricians and the neonatologists are concerned, the first prenatal visit is extremely important. In the last trimester of pregnancy, explore the family perceptions, provide accurate infection, endorse breastfeeding, teach all and a breast model, counseling, and addressing doubts. And in the first newborn visit, evaluate the delivery events, minimize interference and anxiety, targeted education. I said it's not one fit for everybody. Identifying any need to monitor, and you can use the breastfeeding history form and observation form. This is only in the interest, but this should not be conveyed to the mother. We have another situation called as, when we said unrestricted demand feeding, now we have gone into another thing called as Q feeding, which I would not like to propagate among mothers because it will lead them to more confusion for completion on the whatever is happening. So these are the various newborn feeding cues like rapid eye movements, muscle tension, such as a flexed arm or closed fists, etc. And these are the various cues that the newborn is giving us or the infant is giving us. And crying does not necessarily mean that your baby is hungry. So just like we have growth and development, as pediatricians, we could never skip out on growth and development. I just want you all to know that breastfeeding has breastfeeding developmental milestones. The first 2 months, breastfeeding relationships are dynamic. After 2 to 3 months, the infant family establish a predictable routine which is comfortable. 2 to 6 months, it's a time for everyone to relax, start enjoying the rewards and ease of breastfeeding, and the infant suddenly becomes charming. So it is not, it's not just at one shot I'll finish off all the breastfeeding issues. It is not so at all. And look at the breastfeeding developmental milestones. What are the parameters? What happens to the weight? At birth, the baby loses 8%. At 2 weeks, he regains weight. At 1 month, the weight gain is 140 to 196 grams per week. Look at the stool pattern. Look how the feeding is changing. What is happening to night feeds? What is happening to his sleep and behavior? So we should all be aware that breastfeeding has milestones. And also remember that each baby puts a signature in a different way. We have signature styles. You have a Barracuda baby who just grabs the nipple, suckles energetically for 10 to 20 minutes. We have that excited ineffectiveness. Mothers find it very frustrated. The moment he goes to the breast, he gets so excited that he's unable to latch it. And some babies will say, okay, I'll take the feed later on. So the procrastinators, the gourmets, the resters. So remember, every baby has a different signature. He puts a signature sucking style. Now, a word about the healthy term newborn. Suckling hypoglycemia. In many places I've seen, they keep on doing the blood sugar levels in term, I'm talking about the healthy term newborn, and say that the child has got hypoglycemia. Remember, early and exclusive breastfeeding, that too initiating within 1 hour, meets the nutritional requirements. Do not develop symptomatic hypoglycemia as a result of underfeeding. No need to routinely monitor blood glucose. Functionally and metabolically, they are programmed from transition from intrauterine to extrauterine environment. There's another interesting phenomenon. I brought it in here because of the COVID situation, the baby spit backwash. It's so interesting. When a baby nurses, it creates a vacuum in which the baby's spit gets sucked back up into the mother's nipple, where receptors in her mammary glands read its signals. Baby's spit wash contains informations about the baby's immune systems, such as bacteria, viruses, and is the way our breast milk adjusts its composition, tailoring to the baby's particular pathogens by producing specific customized antibodies. I always used to, Rajat and me, were always talking about the microbiome and the bacteria that the baby needs. There are a lot of things that have gone into microbiome theory in breastfeeding. And we have realized that the rise in cesarean births, overuse of antibiotics, infant formula in place of breast milk has destroyed this microbiomes lifelong and resulted in many conditions, non-communicable diseases like asthma, allergies, obesity. So microbiome in our body is affected for good or bad by how babies are born and nourished. So the two most important would be fewer scheduled cesarean deliveries, more mothers breastfeeding exclusively, at least in, I mean, this is a global context, 6 months, but we would want them to continue for 2 years. This is the decision tree regarding COVID-19. It's gone into a lot of arguments, and it's still, I must state, it's very still infantile rather. And Dr. Arun Gupta and his team took up all the suggestions and made this decision tree. I would at the outset like to say that I have no experience attending to a COVID mother. But yesterday I discussed with Dr. Sahana where they have 2 COVID positive mothers have delivered the babies. Only because of logistic reasons, the babies have been kept separated. Otherwise, they want to express the breast milk and give it because the people attending Vanivilas Hospital are extremely poor, commuting from the COVID ward to the place where the babies are kept, they're finding some difficulties. However, a blanket rule would be, please do not separate the babies like the way it's happened. They should be roomed in with a distance of 6 feet, and mother should follow respiratory hygiene and wash her breast before breastfeeding if she is COVID positive. So breastfeeding should go on uninterrupted. As far as the global scenario, my friends are concerned, they are very confident that there is no vertical transmission and there is no transmission from mother to the breast. And I just want to tell you, the scientific evidence is still in its infantile stage. Till we get proper guidance, we have to hold on, I suppose. Thank you very much. I think I finished on time.
Yeah, thank you very much, ma'am. Anyway, I mean, your class is always amazing, and you would cover everything. That's why on this Mother's Day, especially when it comes to lactation management, there is nobody who could match your the way you have explained, ma'am. Thank you very much. I request Naveen sir. Naveen Benakappa sir, are you there?
I was able to finish on time.
Yeah, superb, ma'am. It was fantastic.
Because so much.
Bang on time, and you covered every practical aspects. Even the more than the theory, it is the practical thing which you have covered very beautifully, ma'am.
And I wanted to show the videos, Prashant, but it would take a long time if the videos don't open and all that.
We can show that after
if there's time.
Start. Yeah, yeah. Ma'am, just stop sharing the presentation. Dr. Naveen sir, Naveen Benakappa sir.
Yes, I'm there.
Yes, sir. Yes, sir. We welcome you as well, sir. Can I request you to introduce Dr. Srinath Manikanti, who is a consultant in La Femme Hospital. So please introduce Dr. Srinath and a few words about the presentation, what Asha ma'am did.
Me, I am a big critic-offer.
What
videos? Breastfeeding videos.
Okay.
Dr. Srinath?
Srinath.
I think Dr. Srinath has logged out.
Oh, no, I'm logged in.
Logged in, yeah.
I'm starting my video.
1 second. Aman, make Srinath this host.
Hello,
Hello,
good
I
evening,
think
Naveen
everybody.
sir, please introduce
Yeah.
Srinath.
Good evening, everybody. I welcome, thank Dr. Prashant Dinkar and Dr. Kishore who are doing this wonderful webinar. I would like to welcome Dr. Srikant, who's started this milk banks and is helping a lot of patients, especially we also sent request to him from our NSU, and he was very kind enough. He was the first person to join this venture, and without wasting much time, I would like to welcome him to this webinar. Thank you.
thank you, Naveen sir. It's always a pleasure actually speaking to you. If you can just let me share my screen. I think my screen is disabled. Host is disabled. I think it's screen sharing. Aman, can you just allow me to share my screen?
Yeah. Just a second. Dr. Srinath, you can share the screen now.
I think, yeah, my screen is shared.
Able to see you.
Yes. So good evening, everyone. And at the outset, I would like to pass on the greetings of Mother's Day. And what a fantastic day. And it's always pleasure to be actually speaking to you all. And it's such a privilege to speak after Asha Madam's talk, a very, very passionate talk on breastfeeding. I'm sure you're all convinced that there is no other better food to the babies than the mother's own milk. My talk is about what will happen if for some reason, if mother's own milk is not available, and what is the next best option for especially the vulnerable preterm babies that we have in our NICU. I thank NNF Karnataka for giving me this wonderful opportunity. Thank you, Prashant. Thank you, Dr. Dinkar. Thank you, Dr. Kotesh and team. And in the next 30 minutes, I'm going to talk about the human milk banking aspect. So I had the Amara Human Milk Bank in Bangalore. Actually, it is an initiative set up by Breast Milk Foundation and Fortis Latham coming together. So these are the two gentlemen who actually started the Breast Milk Foundation. The left one is a gentleman, Dr. Ankit Srivastava. He's an industrialist and he's a philanthropist. And he actually donated all the equipment, and he's the man behind setting up this human milk bank called Amara. And to the left of him is Dr. Raghu. He is my counterpart in New Delhi. He is actually the one teaming up with Dr. Ankit to come up with the first human milk bank in New Delhi. And then we decided to actually get the first human milk bank in Karnataka that is set up in Bangalore. So in this talk, what we're going to talk about is we talk about the importance of breast milk banking, but also we'll try and understand the concept of breast milk banking and how to set up a human milk bank. We'll go step by step and we'll show you some videos as well. And we'll talk about the process of human milk banking and what is the way forward. I think I'm audible. One minute.
Yeah, you're audible. You're audible. I think background some noise is coming, that ishing noise, but otherwise it's very clear. Presentation is also very clear.
Oh, thank you, Prashant. So coming to the importance of human milk banking. So after Asha Madam's talk, we all very well know that the breast milk is the best for the babies, and it is 10 times more important in preterm and low birth weight infants, even compared to the term infants. And breast milk has proven to be protective in preterm infants in various studies which has been highlighted. And preterm and IUGR babies, these are the most vulnerable babies who are in the NICU, who benefit more from breastfeeding than any other term babies. because the complications are more in these babies when formula feeds are used. Unfortunately, these are the most vulnerable babies. During the initial phases, these mothers may not be able to lactate enough to meet the demands of these babies. And that is where the human milk banks fill this void by supplying the donor milk from the other mothers to these vulnerable infants till their own mother's supply comes in. I repeat that, till their own mother supply comes in. So the human milk bank is only a stopgap arrangement to provide donor milk to these vulnerable preterm and IUGR babies until the mother milk comes in. So priority is to make sure that these mothers are encouraged to express from the day one, and so that actually as soon as possible mother's own milk is given to these babies. So there are a lot of studies showing lots of benefits to these babies. There's a lot of reduced incidence of necrotic enterocolitis, reduced of late onset sepsis, reduced duration of NICU stay, and they get onto the feeds much quicker if you use donor milk in these babies where mother's milk is not available. And during the pasteurization, so majority of the macronutrients are retained. However, we lose some of the micronutrients. Okay, so retention of immunological proteins are as follows: IgA anywhere between 50 to 100% is retained, your IgG about up to 70%, and IgM is usually destroyed during this process of pasteurization, and lactoferrin and lysosomes can vary in how much they are there. However, anyway, these are immunological proteins which are actually not in the formula feeds anyway. So whatever we have here is definitely being advantage to the baby compared to any formula feed. So there are many studies showing advantages of donor milk over formula, especially when mother's own milk is not available. And this chart summarizes so advantages: decrease in incidence of retinopathy of prematurity, and decreased feed intolerance, and cost. Cost is a major factor in India, especially. If they get onto the feeds quickly, and if they get off the umbilical lines quickly, and the lesser chances of having infection, and lesser duration of an ICU stay, and lesser cost, and also helps in neurodevelopmental outcomes. So coming to the concept of human milk banking, it's very, very simple. It's a healthy mothers who have excess milk after breastfeeding their own babies. And probably if you ask Asha madam, she will tell you breast milk is uh, never a problem if they do the right things in the right time, especially in the first 2-3 days are very, very crucial. And if we help all these babies, the term babies, to get on to the breast in the understand the techniques and then give moral support, these babies get onto these breastfeeding very quickly, and the milk supply will set in. And many mothers produce a lot more milk than what is actually essential for their babies. So these mothers pump out the milk and donate only the excess milk after feeding their own babies to the breast milk bank. And breast milk bank collects this milk from different donor mothers, and we pasteurize this milk using specialized equipment, and we screen this milk for infection, and once it is expressed, it can be frozen up to 6 months after the expression of the milk. And we supply this milk to most vulnerable babies, that is mostly premature and growth restricted babies in various NICUs. And studies have shown improved survival and decreasing infection in these babies who would have otherwise received formula feeds. if the breast milk bank is not there. So in simple, it is a selfless act of one mother to save the life of another mother, baby, who doesn't have enough milk of her own. It's basically altruistic purpose. Going back to the history of human milk banking, probably Yashoda was the first uh, mother. Going back to our mythology, probably Yashoda was the first first mother who wet nursed Lord Sri Krishna, and it has been documented. Wet nursing has been documented as early as 2250 BC. The first human milk bank was set up in USA in 1910 in Boston, and following improved sanitation and good refrigeration, few more milk banks have been established during that period. However, during the emergence of HIV in 1980s, so majority of these milk banks were closed, and there was a rapid rise in formula feeding during that period. In 1985, Human Milk Bank Association of North America was established, and there was stricter screening for donors and better processing techniques and standardized quality checks. So that led to a lot of human milk banks again opening up. And in 2005, International Milk Banking Initiative was established, and world over, many pasture-raised donor human milk banks were established. And currently, we have over 600 pasture-raised donor human milk banks across the world, of which majority of them are in Brazil. Almost 40% of them are in Brazil, which is a developing country, which you can actually look up to. Coming to the scenario in India, the first human milk bank was in Asia, was set up in Dharavi in Mumbai in 1999. And currently we have approximately about 50 human milk banks present in India. They're mainly concentrated on few cities like Mumbai, Pune, and a government initiative in Rajasthan, and Tamil Nadu also is coming up with more milk banks. And Chennai, Delhi, this was before actually the Bangalore actually came in. And there were none in Karnataka before the Amara was actually established. So we had more than 45 NICUs at present at that time in Bangalore, and there was no human milk bank. And that's where the discussion with Dr. Ankit and Dr. Raghu, we felt that so Bangalore is the right place where actually the Amara needs to come in and then help all these vulnerable premature babies in all these NICs without differentiating where these babies are from. So almost all these human milk banks, most of them are in government sectors. Some of them are actually in the private sector. And all these milk banks, how they collect the milk is they collect the milk from either inpatients or looking at the opportunities where the mothers actually come to the hospital, like when they come to OPD or when they come for immunizations. And however, what will happen is if you use this method, there are multiple donors and with a very small fee. Each mother can donate only a certain amount because they come to the hospital only fewer times. And as a result, we have a lot of mothers, and you need to screen a lot of mothers, and it's not very cost effective, and you get very small yield. So that's why these are the human milk banks currently present in India, in different parts of India. So Amara Human Milk Bank is quite different. How is it different? It's one of the very few milk banks in the private sector, and it is not for profit. It is supported by Breast Milk Foundation. And this is the only public human milk bank which caters to vulnerable preterm babies' needs across all hospitals in Bangalore. As it said, we do not differentiate if the baby is in Indira Gandhi Children's Hospital or in Manipal or in Rainbow. It doesn't matter. because at the end of the day, we want to cater to all the preterm babies who are, who are needing the human milk. And it is a first milk bank in India with collection and delivery service. In fact, when we started, actually, even the Swiggy was not actually established at that time. Okay, so we actually started uh, collection and delivery service to help collect the milk at the comfort of the mother's home, so that they don't need to come into the hospital every single time that they donate. And it makes the collection so easy and comfortable, and more mothers will come forward to donate. And also the delivery service, we deliver to the directly to the NICUs, and we do not give it to the parents. The reason is it can be misused, and that's why how we do that. I'll just go through the process how it's done. And it's one of the first milk banks in India with breast milk analyzer. We have a state-of-the-art Miris breast milk analyzer where we label the nutritional value of the milk and printed on each bottle. And this picture is on the inauguration of the Amara Milk Bank in Bangalore, and it was inaugurated by the Vice President of European Union at that time. So what are the equipment which are used for setting up the human milk bank? So we need definitely one pasteurizer. So you can decide on the size of the pasteurizer depending on how many bottles you want to sterilize at one point. Okay. So the one which is here is T30, and the other one, bigger one, is T90. Okay, pasteurizer. And we need at least 2 deep freezers, at least one deep freezer where we can actually collect all the unpasteurized milk, and we need at least another deep freezer to collect. And once the pasteurization is done, then better to keep all these bottles in a different deep freezer. And at least we need one refrigerator, that is to thaw the milk. Because once the milk is in the freezer, then before you actually do the pasteurization, you need to thaw it. So the best way to thaw it is to keep these frozen bottles overnight in the refrigerator. So that's why we need a refrigerator. And we need one laminar flow. And why do we need laminar flow? Because we get milk from different mothers. And we need a particular ml of milk to do one pasteurization cycle. For example, the milk pasteurizers that we have, it needs about 1430 ml each time that we pasteurize. Okay, so it takes up 11 bottles of 130 ml each. So we need to pool different mother's milk to make up this 1430 ml. And when we pool this milk, when we thaw the milk, we need laminar flow so that we can mix this milk under controlled aseptic conditions. And human milk analyzer and ultrasonic processor is actually not mandatory for setting up a human milk bank. It is optional, where advantage will be that we can actually analyze this milk and we get to know how much protein, how much fat, and how much calories each batch has got. So how does it help us? That will help us in making a decision which batch milk to be given to which baby. For example, I get about 3-4 requests every single day. Then I get different requests, one from 26 weeker, one from 28 weeker, one from 30 weeker, one from 32 weeker. Then I can look at these batches and see which batch has got more proteins, which batch has more calories. Those I can actually given to the lesser gestation babies, like 26 weeker or 28 weeker. So, and also it will help us to keep the preterm mother's milk separate and then pasteurize it separately, so that we get more protein and calories in those batches. However, the breast milk analyzer is very expensive, and not all breast milk banks will have the breast milk analyzer. And we need automatic and electrical brush pumps, because we need to lend these pumps to the mothers who do not have pumps of their own. If they have their own pumps, we'll let them use it. And then otherwise, they can lend these brush pumps from us as long as they keep donating the milk. And we need BPA-free container bottles for milk storage and supply. And some of the milk banks in India, they use stainless steel, so that can also be used. And here we go with the standard SOPs from uh, the NICE guidelines that we follow, and we use the BPFT containers. And we need one cool box that is to transport this milk from our NICU to the different NICUs, and also to collect the milk from home of the mother and bring it back to our milk tank and maintaining certain temperature. So that's why we need the cool box. And always I get questions from different friends who would like to set up human milk bank about how much does it cost to set up a human milk bank. And this is what I have put up. Uh, it varies depending on what the type of equipment you want. So that's what I told you. The human milk analyzer is very expensive. So that is not actually mandatory. So it can be optional. So if you remove the human milk analyzer, so probably you can set up a good human milk bank. So probably with the cost of about 20-25 lakhs. So you can set up a very good one. So how does Amara work? Sorry, I just lost. Is my video visible?
No. Video is not played yet. We can only see the
A
slide.
screen. Yeah, you can see the slide, right? Okay.
Amara,
Yeah,
we are seeing
video.
the yeah.
Yeah, video will come shortly. So Amara, how does it work? So we first identify and motivate these mothers. How do we get these mothers? So many mothers do come forward after looking at our website or looking at the, uh, probably Google Google Human Milk Bank, and then they come to us. And also some of them who have read in the newspapers or who have probably seen in the TV, so some of my interviews. So these mothers actually are very motivated. They do not want to waste their milk, so they would actually some of them would have already started storing the milk, okay, and in the freezers. And by the time they call us, they would have already uh, uh, bought a sterile the plastic containers which are available in the supermarket, and they would have actually named and dated it, and then they would have stored it. When we started the Human Milk Bank, the very first day, one lady who came from US, and she had already collected about 5 liters of milk, and then she called me and she said so she wanted to donate. So that's how actually the mothers will come directly to us. And also, so many of our colleagues are referring mothers for donation. And uh, nowadays, we are supplying almost every hospital in Bangalore, 46 NICUs, and many of them in turn actually call me and tell me that they identify a mother who's producing much more milk and she would like to donate. So what we did initially was we did CMEs to sensitize the obstetricians, lactation consultants, and the neonatologists. Because it was a new concept at that time when we started in 2017 in October. It is a first new human milk bank, so it was a new concept. So we did series of CMEs for these uh, key, uh, the clinicians and the lactation consultants. And we also sensitized and educated and motivated mothers for breast milk donation in various forums that we get opportunity. And we sensitized pregnant ladies for milk donation, whoever came to our hospital. And also we requested the same for other clinicians in other hospitals to identify and sensitize these pregnant women during the pregnancy itself. And so, as you said, we had tie up with most of the hospitals in Bangalore, and that's why the collaborative effort actually came in. And we started a human breast milk donation drive. We had few celebrity endorsements, and TV interviews, and the newspaper interviews, and that has helped us to get the word out. So coming to the screening process, first once the mother comes forward to donate, so we ask a series of questions. So is the mother healthy? Is the mother on any medications? And if mother is not on any medication, a few medications are accepted, like probably taking thyroxine or insulin and some vitamins. These are exceptional. Other than that, so we would not uh, take milk from any mother who is on any long-term medications. And also we take the history of whether mother smokes or takes alcohol, and those mothers uh, we cannot accept milk from them. And these days, since it is a COVID time, so we start asking questions about whether the mother has fever, cough, or any signs and symptoms of COVID, or any family members are at risk of having COVID. So if any questions is yes, then we would ask her to not to collect and store the milk. Okay? And then we'll get back to her after 2 weeks, and then probably check her again. And if she's healthy, then we'll ask her to start collecting the milk. So we'll first take the consent from the donor, and our nurse will explain to her about completely about how hygienically she has to express milk, and we will ask her for blood tests, the initial screening tests during the pregnancy. We ask for HIV, hepatitis B, hepatitis C, and VDRL, and if they're all negative, then we'll send a lab technician to their home, and then we collect the blood, uh, and we process this blood free of cost and at our cost, and to make sure that all these mothers who would like to donate milk are coming negative for all these infections. So once the donor is registered, so as I told you, we educate regarding hygiene, skincare, and milk expression, and how to handle and how to store and sterilize the breast pump. So majority of these mothers are who coming to us are middle class and upper middle class. So most of them have fridge and freezer at home, and they follow the instructions, and they collect the bottles according to how we advise them. And we usually give sets of 5 bottles of 250 ml to each mother once they are registered. And we'll encourage them to label these bottles as soon as they express with the date and the time. And each bottle can be expressed and filled it up and kept it in the fridge up to 24 hours. And once the 24 hours are over, or once the bottle is filled, then we'll encourage her to completely close the bottle tightly and put it in the back of the freezer, and take the next bottle and start working the milk. And once 4 bottles are completed, then she can give us a ring, and then we'll send our runner with another 5 bottles, and then he will collect the 5 bottles which are already pumped, and then we'll give another 5 bottles for her to collect. So our runner from Ambara collects these frozen milk bottles from donors, and milk is delivered to Amara in a frozen condition. We use the cool bag, as I said. And this is the milks which are already pasteurized on the right-hand side. So immediately we put this milk in the freezer. So these are the 250 ml bottles which they would have given to us. So coming to the pasteurization, so these milk bottles which are actually given to us are 250 ml milk bottles. We call it as a raw breast milk. Okay, so it's not pasteurized yet. So we have a color coding system where unless we get the mother's blood results, we do not put a sticker on that. Once we get the blood results and they're negative, we put a red dot. So these bottles which are having a red dot, they are ready to be pasteurized. We need about 1430 ml each cycle. So we take appropriate number of bottles, and they are frozen currently. And those frozen bottles will be kept in the fridge overnight. And by the next time morning, when the nurse comes in, then it will be thawed, these milk. So the frozen milk is thawed overnight, and these are pulled into a smaller containers of 130 ml bottles, because that is what our pasteurizer takes in. And so this pooled milk is mixed under a laminar flow under complete aseptic, using all aseptic precautions. And we pasteurize using Holder method, that is 62.5 degrees for 30 minutes. This is standard method across all the human milk banks all over the world. However, some human milk banks now are coming up with newer techniques, which is not yet validated. And soon after hot method, it is cooled automatically immediately in the same pasteurizer. And after we pasteurize this milk, we take one bottle and take samples for milk analysis, as well as we send the cultures of the milk. And remaining 10 bottles, we change the color coding from red to yellow. That means they are pasteurized, but still waiting the microbiological culture report. And we put them back in the freezer. And the one bottle which we have taken, the milk, that is that bottle, sample bottle, we keep it even after dispatch of the dispatch. We check for any discrepancies in case if any of the hospitals report any infection to the milk baby, then we can have this batch reference, one sample which is kept. So then we can actually check this for infection. So for quality control, we keep that bottle. And the milk is frozen again, and it can be stored up to 6 months once it is frozen. So this is the breast milk analysis of the milk. So average, usually we get about 1.1 to 1.5 grams of protein, and the fat anywhere ranges from about 3.5 to 4. And energy varies. If it's a preterm milk, probably we get about up to 85 kilocalories. And if it's a term milk, sometimes we get up to even 67, 65. So it varies depending on the composition of the milk and from which mother it is collected, and how old the milk is. For example, if it is pumped within the first 2 weeks after the delivery, then the calorific value will be high, proteins will be high. If it is 3 months after delivery, then it will come down. So once the culture is sterile, the milk is ready to be dispensed. And you can see here, some of them are yellow stickers. Yellow stickers are which this batch is still waiting for the culture report. And green label is where these bottles are ready to be sent, because the culture reports are negative. And each bottle is actually neatly labeled using waterproof labels. And we need a prescription from a neonatologist or pediatrician. Without that, the milk is not to be given. And ours is purely a medical milk bank. It is not a commercial milk bank. And the culture negative frozen milk will be dispensed after receiving the prescription. And we take regular feedback from recipients' clinical status, and to see if any concerns about infection, then we will look into it. Fortunately, so far, we didn't have to do the reculture of the sample bottles that we have, because we did not encounter any serious infection in the babies that received the Amara milk. So what are the, for which babies do we give this milk? So we set up this milk bank to help the vulnerable preterm and low birth weight babies. And that's where we actually sticking to. Majority of these conditions need to be fulfilled for us to give the milk. For example, every day I get about 4, 5, 6 requests, and then I go through the requests each myself and look at whether each baby fits into the criteria or not. Nowadays, because of the COVID, we have reduced our working hours. Previously, we were working every day. Now we are working on alternate days, and we have been much more stricter in choosing which babies get priority over which baby to get the milk. So we don't look at which hospital they come from, but we look at which baby is most eligible to get this milk. And we do not issue donor milk for term babies or babies who are born to surrogate mothers. We do not issue uh, milk to the babies who have been discharged home and without doctor's prescription. And initially, when we started, there are issues in convincing the donors to come forward and donate, and also we had to convince the recipients about the use of the donor milk. So far, we have about $270 who have donated almost 991 liters of milk, and about 447 babies have been benefited, and over 46 NICUs. And this is the various statistics of each baby, 500 to 1,000 grams. That is when we reached about 347 babies, and majority of them are preterm and very low birth weight. We conducted workshops for doctors and nurses. These are some of the mothers who are donors and recipients have come to these workshops as well and share their experiences. These are some of the coverage in the media. These are the parents of triplets. Both are doctors, and the triplets are doing very well right now. And Mother Shweta is there currently in this webinar, and we can actually take her to share her experience. This is one of the very motivated mothers. She is a donor mother, and who is currently doing DM in neurology in Vaidehi Medical College. You can just have a look at feedback from her briefly before we go to.
Volume, we are unable to hear.
Oh, you're unable to hear, is it?
I think if she's around, we'll take direct feedback from her.
Okay, okay, we'll take directly. That's fine.
Okay.
Okay.
Yeah, sure.
So I'm showing you a brief video about how this milk bank process is. This is a 30-second video. First, you watch this video, and after that, I'll take you alive and you go in detail about. I'll take you through each and every process. You can first watch this 30-second video. Sorry, 1 minute. Oh, can you hear the sounds?
No, audio is not there.
Not there. Okay.
Yeah. You
Now,
can do a commentary. It's okay. Audio is not there.
audio is not there. Okay. So now the sister is taking the unpasteurized milk and she is thawing it in the fridge overnight. These are the frozen milk. Now we are going to thaw it overnight to make it liquid. The next day morning when we open the fridge, the milk is thawed. And these milk bottles are mixed under the laminar flow using aseptic technique. And this milk is put in smaller 130 ml bottles. And we cap this milk with a seal cover. And we take 11 bottles and we put in the pasteurizer. This is the hot method. Once the hot method is over, we put it in the cool chamber. Once the cool chamber is over, it is rapidly cooled. The milk is taken up and we take one bottle. We change the color code to yellow. And we take about 8 ml of milk, one for culture, one for milk analysis, and we print the labels. And once it's pasteurized, we put them back in the freezer. These are green labels which are ready to go. So this is the process how we actually go through. I will take you to videos right now. So these are some of the pictures of the human milk bank. And these are the bottles that we use to store the milk. These are BPA-free containers, and these are the breast pumps that we give to the mothers. After they return the breast pumps, we EPO and then we reissue them. These are some of the leaflets that we give to the mothers to educate them. So this is the front of the milk bank. Now we are going to enter the milk. And as we are entering, this is Sister Suki. She is in charge of the human milk bank. And these are the computers where we store all our records. These are the printed labels. There are a lot of documentation in these cupboards. And we have two deep freezers. One is a thermoscientific deep freezer where we keep the pasteurized milk here. After the pasteurization, the temperature is minus 20 to minus 30 degrees. This is another deep freezer where we keep the milk collected from the mother, the raw milk. And when you open, we have the milk in the bottles with a mark of red. That means we are waiting for the mother's. We have already got the mother's blood results and they are ready to be pasteurized. And we also receive milk from mothers. Some of the mothers would have purchased the sterile polythene bag containers, and that can also be uh, collected from the mother. And here in this freezer, we are maintaining the temperature of minus 22, minus 25 degrees. These are all frozen. This is again the milk donated by the mother using collected in the sterile containers. And this also mother's blood results we have received and they are ready to be packed. And in the other set, we have collected other bottles. Some of them are still waiting for mother's blood results to come back. So that's why some of them do not have these red stickers. At any point, we have usually about 15 to 20 liters of milk in the deep freezers. And if excess milk is still being collected, and we ask them to store it in their own freezer and we'll collect them later from their home. So now we are entering other section where we do the pasteurization, and The milk is kept overnight in this fridge, and that is thawed. The milk is now thawed, as you see, and this milk is ready to be mixed under the laminar flow and put into smaller 130 ml bottles. So we take this milk and we mix this milk under the laminar flow using taking sterile precautions, and put into those 130 ml bottles. We'll show you the process in the next video, how to do that. These are the 130 ml sterile containers where the milk will be put, and then after that, these bottles will go into the pasteurizer. During pasteurization, we put 12 bottles, of which one bottle contains water, and we monitor these bottles' temperature using a tiny tag. It's a device which actually records the temperature, and these temperatures will be put back into the computer for the record. And these bottles are sealed. Once the bottle is sealed, you can see that the bottles have a complete seal before they go for the pasteurizer, so that no one can actually tamper with them. And we advise all the hospitals to look for this seal, and if any tampering of the seal, we ask them not to use the milk. And once these bottles are filled in 130 ml bottles, and then they go into this is a steady feed pasteurizer that they have, and it is imported from UK, and it has got hot and cold method. Orange is actually hot chamber, and the blue is the cold chamber. In the hot chamber, it maintains a temperature of 62.5 degrees for 30 minutes, and once the once it is the hot process is over, it is given alarm. After that, we remove that and put it in this cold chamber. And we fill before we do that, we fill this thing with 130 ml of water. And this is a tiny tank which actually records the temperature as the process goes on, and all these temperatures will be fed back into the computer and for each batch, and that will be stored. Now, once the pasteurization is over, so we take one sample bottle and then we take milk for culture as well as for milk analysis. So that bottle will go for the culture, and the remaining milk we analyze using the milk analyzer. This is a sonicator where we mix the milk before we actually put into the milk analyzer to get the even composition of the milk. We do even analyze the milk separately if any of the hospitals request milk analysis if the baby is not growing very well on mother's own milk, to look at the composition of the mother's milk. For that, we request about 50 ml of express breast milk, where they completely empty the breast. And those 50 ml we take, and then we first use the sonicator to evenly stir it. Then after that, we take about 5 ml of the milk from there, and we inject that milk into this milk analyzer, and it analyzes and gives us the printout. So this is a Miris analyzer. Currently it is being calibrated. So once the calibration is done, the system will inject the milk into the analyzer. After the injection, it takes about 2 minutes for it to analyze, and then it will give us the printout. So now we'll take you to, once the pasteurization is done, now all these pasteurized bottles are stored in this deep freezer. And you can see in one batch, we have yellow sticker, and these bottles are labeled. And these are all the bottles where the culture is awaited from the milk. So if it is culture positive, then we'll have to discard this milk. If it is culture negative, then the color code will change into green, and they are ready to go. And each and every bottle will have a label with an expiry date there. And we store it in different compartments. And those are the sample bottles which are kept for at least 1 month after dispensing the batch. So that's for reference. And this is a cool box where we actually carry the milk, maintaining about 15 to 20 degree, so minus 15 to 20 degree temperature. We use the cool box to collect the milk from the mothers from their home, as well as to deliver the milk to a different NICU. This will be carried by our runner. During this lockdown period, we had to take special permission and to go, and we have taught him all the precautions, how to use the mask and social distancing and hand washing. This is a dishwasher where we wash the bottles after they have been returned to us from the mother, as well as from the NICUs. We request all the NICUs to return the bottles to us. And this is the sterilizer, bottle sterilizer, to sterilize these bottles. And after that, they are good to be pasteurized. Now we'll show you a process how to mix the raw milk. So we need about 1430 ml, and we mix all these bottles into the sterile container. When the nurse comes first and she switches on the pasteurizer, once the pasteurizer heats up to 35 degrees, then she switches on the laminar flow, UV light. And once it reaches the temperature about 50, then she switches off the UV light and starts the fan. And under that, then using all the aseptic precautions, then she mixes this milk and puts them in these small 130 ml containers. And we seal all these bottles before we put them in the pasteurizer. So we need about 11 bottles for each cycle. Prashant, am I audible?
Yeah.
Yeah. This is the last slide. Okay. So what is the way forward? So we have shown you how to the process of the human milk tank. So for a country of our size, definitely we need to establish more human milk tanks, and they need to be regulated. And as I said, ours is for not-for-profit organization, and we charge a very nominal of 2 rupees 30 paise per each ml. And we do not incentivize any mother. And for the fact that, so once we start incentivizing, it will become more commercial, and a lot of uh, of, ethical issues will be there if you start incentivizing the mother. And we supply free of cost for any baby who is in government hospitals and who have any baby even in private hospitals who have BPL card. And we charge only nominal cost, that's 2 rupees 30 paise per ml, which we started in 2017, and we still maintain the same cost. And although our cost of our expenses are actually increased, and we lost so many bottles, and more than 300 bottles have been lost in the transit. And then that's the reason we request the NICs to return the bottles back to us to make it still cost effective and efficient. And having this robust delivery and collection system reduces the cost, and we have less number of donors, but we have got a more ease. And so each city can have about 2 to 4 milk banks which can serve all the premature babies, and more milk banks need to come up in each district of the each district hospital, because more and more NICs are coming up in the peripheries, and these babies require human milk. And we need to increase the public and awareness amongst the doctors. And there are newer methods of pasteurization are being tried, like flash pasteurization, UV pasteurization, to retain most of the micro nutrients, but they are not still validated. Thank you very much for your listening, and we would like to take up the questions moderated by Dr. Prashant and Dr. Bhagwan.
Yeah, thank you very much, Dr. Srinath, for your wonderful presentation. And literally, you took through the human milk bank and how it is done and what it takes to actually to reach the milk which is required for an extreme premature baby. Today, I'm extremely happy that we have been joined by two mothers who themselves are doctors, and from on behalf of entire neonatology fraternity and the pediatric fraternity, we would like to salute you for the service what you have done. And you have not just been taking care of your baby, you are concerned towards the other babies who are in need, who are extreme premature babies who would survive, thrive only with the milk which is donated by you. Thank you very much, Dr. Soumya and Dr. Shweta. It's I would We would like to listen few words from you as well, because you are an inspiration for so many mothers, and you're actually on this Mother's Day, you're actually fulfilling the role of a complete mother which our nation needs. Thank you very much, Dr. Shweta and Dr. Soumya. So I request Dr. Shweta to speak a few words, and then I request Dr. Soumya to speak a few words and your experience and feedback. We are extremely proud and happy that you have joined us, and big salute from all of us for what you have done. Thank you very much. Can you share your experience and what motivated you to take up this noble cause?
Thank you so much. So I am Dr. Shweta Kamath, and MBBS graduate, and my husband is Dr. Anappa Kamath. He is a psychiatrist. So we were in Bangalore, and that is when I conceived triplets. That is 2 girls and a boy. So that was in November 2017, and they were born at 31 weeks 5 days, and they were each were weighing about 1.45 to 47 grams. So and it was an cesarean section, so I just developed pain, so that's why. Otherwise my date was actually in December, so suddenly I had to go into labor, and that is how they were delivered. So once they were delivered, they were shifted to NICU, and after I reached back from the postnatal ward, so when I was shifted to the ward, and I just stayed for 2-3 days, but I did not have enough milk, and that was the major concern. So my pediatrician was Dr. Vishwanath Kamoji. I delivered in Columbia, Asia, Hebbal. So he suggested that you need to pump some more milk. So at least it should feed at least one time for all the babies. So I used to have a minimum of maximum, I can say about 100 ml, not more than that. I tried pumping anything, taking medications, nothing worked. So then he suggested that you can take the decision of giving the formula milk. formula milk, I had already thought about it, because if I deliver prematurely, if the babies are premature and I do not have enough milk, that's the only other option. But then he also suggested that one of his friend, that is Dr. Srinath, has opened Amara Milk Bank, and that is very recent. If you are open for this option, you can also go ahead. So we were a little bit apprehensive initially, because that was totally a new concept to us. But then we thought, okay, we will give it a try. We will see how the babies take it. If they like it, then we will continue with it. So then we ordered the first set of 3 to 4 bottles on one day, and we gave it to the babies, and they really liked it. So then Dr. Vishwanath said they are liking it. So will you still continue with Amara Milk Bank, or you want to continue with the formula feed? So we gave an option of continuing with the Amara Milk Bank donor milk. So if there is enough, not enough milk for our babies, then maybe we can switch it to the formula feed. So our triplets stayed in NICU for almost 3 to 4 weeks in NICU in Columbia, Asia. So all through their stay, they had received donor milk, and I feel we were the highest consumer for the donor milk during the duration. So that is when, and at almost the discharge, they had lost some weight in between. So at the time of discharge, after 1 month, they almost regained back to the normal weight, that is around one. They reached around 1.5. So then they were discharged home. So I thank Dr. Vishwanath for suggesting me this Amara Milk Bank, and Dr. Srinath for taking up the initiative. And I very much needed initiative for all our babies who are premature. And I also thank the donor mothers who are coming forward to help and save the babies. Thank you so much, everyone.
Request Dr. Soumya to share her experience with us. Thank you, Dr. Shweta.
Thank you.
Hello, good evening. So I'm Dr. Soumya. I'm doing my DM neurology now. So my baby was born in September 2017. So after that, I think when he was around 15 days old, I got my DM neurology seat. So at that time, I was very adamant about breastfeeding my baby. So what I was doing is I had to go back after 2 months of maternity leave. So I started storing milk in addition to feeding him, so that he has enough milk when I go for work. So when I started work, I realized that I was producing more than what he needed, because I was simultaneously pumping and feeding him. So I had enough milk, and I didn't know what to do with so much milk stored in the fridge. So then from US, I heard from my friends that there's this concept of breast milk banking there. And I was wondering if such a thing exists in Bangalore. So I read about Amara in Google, and I just called up Dr. Srinath, and I contacted him, and I asked the procedure, how to donate. And then so already I was storing milk, so they were in the breast milk bags. So I donated in bulk at the end of like 3 to 4 months, I think. Then after that also, I kept on donating milk to the breast milk bank. I donated about 5 months, and almost about 13 liters of milk, I think. So I was very happy that the milk is being used for so many vulnerable babies, and it's really inspiring. I've visited the bank, the milk bank. It's so clean, and I think everyone should get to know about this. There should be more breast milk banks everywhere in smaller town cities, and I actually encourage many of my friends also to donate, because it's such a nice initiative, and I really appreciate them for taking it up. So thank you.
Thank you, Dr. Soumya. I mean, you sharing your experience and what motivated you to donate the milk is really inspiring. Definitely, this feedback what we have given, we would like to reach every mother who could offer their milk to the needy people. Trust us, as a neonatologist, if baby is not tolerating the milk, or if mother is not having sufficient milk, and we're supposed to give formula milk. With human milk, it is like magic, and that's the beauty of human milk. And you are doing a wonderful job you have done. Thank you very much for that. Before we enter into the session, thank you once again, Dr. Soumya and Dr. Shweta. Before we enter into the discussion, we have Dr. Devraj Raju sir, who was our past president, NNF Karnataka. Thank you very much for joining. And he is law. I'm sure he is the expertise in law and legal experience will help in the coming days. Sir, we want to know what you feel about the NNF Karnataka, how it has gone, and your views on medical aspects of human milk. Before we start discussion with, we have Asha ma'am still with us and Dr. Srinath, and there are a lot of questions. And after this, I request Dr. Raghavendra to coordinate the session. So Devraj sir, please share your experience and medical legal aspects of the thing and about the NNF.
Yeah, thank you, Dr. Prashanta Gowda and Dr. Dinakar for inviting me to be with you today. And my respectful namaskaras to Madam Asha Benakappa. There is a lot for me to learn from her, and I think it is forever, because every time I listen to her, I learn something new, even though breastfeeding is so-called a common subject. Coming down to the legal aspects that I see, especially with human milk banking, which Dr. Srinath Manikanti has very nicely covered, and it was an inspirational speech from him also. Maybe with his speech, now we are going to probably will have more milk banks in Bangalore as well as in other parts of Karnataka and in the country, because I know that this webinar, which is being conducted by NNF Karnataka, is being participated by people around India, not just in Karnataka, and that is a proud moment for NNF. And I congratulate the President Secretary of current President Secretary of NNF and Dinakar and Prashanta Gowda profusely for this, and I'm proud of you all people. Coming to the legal aspects, as I was speaking, what I see is, as of now, it is still in the budding stage. So people are still accepting it, and doctors are venturing into it, and therefore, as of educated people and those people who are legally educated are less. But they may not be like this in the coming days. So what I would see is informed consent is very important aspect of this human milk banking, and Dr. Srinath has covered that, especially risk of transmission of infection, even though it is very less with the pasteurization, and we need to communicate clearly that that part of informed consent, communicate clearly the risk of pasteurization versus risk of giving other milks like the infant formula milk and wet nursing. And there are certain aspects related to religious issues which also have to be addressed in the informed consent part. And we need to give very objective information, and when they have any issues in deciding, then we may help with our inputs. And another aspect what I see is record keeping, because nobody has bad intentions here, but when any problems happen, then the question of negligence comes. And in criminal law, there should be a bad intention to call it as a criminal case, except in cases of negligence. So when negligence aspect come, then one may land in problem. Therefore, keeping records is important, and that should be meticulous. And how long to keep this is a very debatable part of it. Whether to keep it 3 months, 3 years, 5 years, 10 years. Some of the American associations or institutions say that we should keep it 21 years. And even another group says they should be kept for 30 years. And Indian experts feel probably it is not necessary to keep beyond 5 years like how we keep it in blood banks. This what is the recent thought about this record keeping. And maybe we don't, because we don't have government legislation as of now. But if any commercialization happens within human milk banking, which is likely, even though we do not pediatricians discourage that. But if it happens, then legislations may become necessary to protect the rights of mother as well as the babies. And so let's see what happens in the future. But as of now, let's keep working with good intentions, with the public and mother and baby interested motive, and all the best for human milk banking. So that's all
Thank you,
from
sir.
my side. Yeah.
Thank you, sir. Thank you, sir. Thank you, sir. We'll quickly move to the discussion.
Yeah.
Asha ma'am, Dr. Srinath, Dr. Raghavendra, kindly, let us start the discussion with a lot of people come up. Over to you.
Yeah, thank you, Prashant. Yeah, good evening, ma'am. You have covered full topics of lactation management. It was a wonderful speech, and you have seen you are continuing the legacy of our late Nirmala Kesri madams. And I just want to moderate few questions. There are a lot of residents, fellows, and consultants. They have come up with few questions in the chat box. Just let me discuss some questions. Madam, can you just tell about managing breastfeeding in a working mother?
I deliberately did not go into that issue. So it's another session. Like whenever there is a working mother, the last trimester of pregnancy, we have to discuss breastfeeding and working mother program. So I'll see if I have a PowerPoint in this WBW 2090. So what happens? We have to find out when she's reporting for work. Second thing is how long she's away from the baby. So I'll take an example of the routine from 9 to, if the woman is going for work from 9 to 6 p.m. Okay, then what we should do if the baby is less than 6 months, she should ideally report for work on a Friday so that we get Saturday and Sunday to know what the problem is. The whole working woman and breastfeeding program is for 12 days. It takes 12 days for her to establish that rhythm. The first thing that she does is at 6 a.m. she gets up and breastfeeds the baby. Immediately after that, she'll express the breast milk from both the breasts. And just before she leaves for work, she'll breastfeed again. So this expressed breast milk, you can go on keeping it in the fridge. If she has a two-door fridge, and if the milk is going to be used within 24 hours, it can be kept in the first shelf. And in the chiller tray, if it is beyond 3 days, then the freezing. Ideally, I do not advocate freezing because we lose a lot of nutritive value of that milk. And then when she comes back from work, she'll do direct breastfeeding. At work, she'll continue to express the breast milk and carry it in an ice container and bring it back home and keep it in the fridge for the next day. Once the milk is removed from the fridge, she's going to put that into sealed containers. We saw a lot of sealed containers with Dr. Shrikant's presentation, and she'll put it into one more cup, that milk, and that milk will be kept in a hot case which contains boiled water. Never do direct boiling. So this is the advice we give for the working mothers. And I have any number of working mothers. I have the lactation helpline. So I have any number of working mothers who have successfully exclusively breastfed for 6 months and continued breastfeeding after 6 months is not an issue at all.
Yeah, that's nice, madam. Madam, one more question by the residents. Managing breastfeeding in twins and triplet babies, madam. That also they wanted to discuss with you.
Yeah,
so can you just guide
even in is the video open?
Yeah, madam. It is visible.
Yeah, I'll just show you the videos. Even triplets, I have triplets from the famous Rajkumar family, and now they are 15, 17 years old. All three have been exclusively breastfed. Remember one thing, breast is a wonderful factory. The more you feed, the more milk you will get it. And I'll just show you the videos of twins feeding. I'll just show you. So twins can be exclusively breastfed, no issues with triplets. And we have globally 6 children being exclusively breastfed. So it is all how you convince the mother. Where are the videos? Yeah. Breastfeeding twins. Breastfeeding twins.
Twin feeding.
Yeah. Yeah. So this is a video of twins breastfeeding. Can you see that? Can you see that video?
No, you need to share screen, and then select video.
Where is the share screen?
Down. Share, like how you shared the presentation. Same way.
Yeah.
Share screen, select that one, and then share.
To share the screen.
Can you share?
Yeah,
No,
zoom.
the screen is not showing.
No, it should be there.
Yes, sir.
The zoom
There.
down. There
One
is
second.
Share computer sound, optical screen sharing, share.
I know this, mom. 1 second.
meanwhile Dr. Raghavendra.
Yeah.
Either short questions.
A few more questions. Can I discuss with you, madam?
Yeah. With Srinath.
Madam, when does routing sucking and swallowing reflex coordinate, and how you manage a preterm baby's feeding? That was one more question which was asked by residents.
One thing is, I told you when those reflexes appear. Sucking reflex at 12 weeks, then 28 weeks is the rooting, and swallowing reflex is the last to appear, 32 weeks. So ideally speaking, at the end of 34 weeks, the baby is able to suck, swallow, coordinate. Birth weight, because in many government institutions where there's a gestational age assessment, it cannot be done in peripheries. The simplest way to say is a baby more than 1.8 kgs has good suck, swallow, coordination. A baby less between 1.5 and 1.8 kgs can suck, can also swallow, but he may aspirate. Therefore, in such situations, we say supervised express breast milk. And below 1 kg, definitely, it will be express breast milk through the orogastric feeding. So this, I don't know, can you see the video now?
Yeah, ma'am, we can see.
Okay, this is twin feeding. So what happens if you have triplets? At the end of the twin feeding, again you take back the baby to another breast, and it can the other child also can be fed. But it needs lot of motivation and support for a duration of 6 weeks. You know, there will be a lot of issues. The family support, somebody should support this mother and baby. So here we have one baby which is agitating, but the other baby is calmly feeding. So you can see that. So this is twin feeding. Okay, next. What was the twin feeding they asked? Then suck, swallow, cord. Anything else, Prashant?
Madam, other question is how you manage a sore nipple, madam? That is what one more question.
The most important thing is sore nipple is improper attachment at the breast. Why does the sore nipple? Can you see this model? Can this model be seen, which I'm holding?
Yeah, madam.
Okay. Why does sore nipple happen? Remember one golden rule. Nipple is just an outlet. It hardly takes part in breastfeeding. Like I'm sitting in a room, the door is an outlet. Majority of the activity is happening in the areola. Sore nipple happens when the baby is improperly latched at the breast. Very often it is because the mother does a hold like that, thinking that the baby will not be able to breathe. Therefore, she's only the child is biting on the nipple. Therefore, you get sore nipples. The best way to correct sore nipples is to teach the postgraduates how the baby should attach to the breast. If I want to do it now on myself, it is like that. My hand has to completely go below the breast so that my chin touches the base of the breast. And only then the sore nipple will be sorted out. So when I have done a wrong, I have to correct it. So at the end of a feed, initially the mother will move away from the breast because it's so painful. You must gently express the milk because the soreness is in the front, but expression can be done near the areola, and apply the latter part of the breast milk, which is hind milk, which is very rich in lubricants and antibodies. Then once slowly it starts healing, you must retry the attachment properly.
Yeah, thank you, madam. Madam, and one more question from the residents. Madam, you spoke about the baby split back wash technique, madam. How does it help in, how does it help the baby? That's what they were asking, madam.
No, it's a new concept. So, I don't want you to take it straight like that. Supposing the baby has got some viruses in the mouth, okay? And this virus in the spit wash technique will enter the breast. And in breast is a beautiful chemical factory. If I have a virus A, if that virus enters the breast will produce the antibodies. So in the next feed for that virus A, we have ready-made antibodies. So this is a newer concept that's coming up, and a lot of publications are there.
Okay, madam. Madam, and final one more question, madam. Since it's a COVID crisis, what's your advice for us regarding the breastfeeding, motivating breastfeeding in the mothers who are recently delivered, like asymptomatic, symptomatic mothers who
I
are
have
admitted in the hospitals?
asymptomatic, symptomatic, and suspected
And
mothers.
sick mothers, yeah, madam.
Yeah, all of them should breastfeed. Number one. Number two, how are we going to breastfeed? Is that the mother will follow strict respiratory hygiene with medical masks. The whole issue is for 14 days only, isn't it? We're going to test her, and at the end of 14 days, if she tests negative, it's such a good relief for us. The whole tense situation is for 14 days. So follow respiratory hygiene, use a medical mask, and every time when the baby is taken to the breast, ensure that she sanitizes that breast. And the baby also should be properly covered except the mouth, and sanitization of the breast. This is what the consensus statement from World Alliance on Breastfeeding Association, World Health Organization, ICMR, and BPNI. We do not want to separate the babies, deprive the baby of breastfeeding, and land up with issues which we encountered with HIV. Initially, we said no breastfeeding and replacement feeding. Subsequently, we learned very bitter lessons because the mortality, morbidity, and malnutrition increased. And then we said, okay, we'll go ahead and breastfeed. So let's not get into that situation. That's exactly the reason why I called up Sahana yesterday and found out what's happening. And they said because of logistic reasons, they have done this. But she said, definitely we're going to ask the mother to express and throw, even if she's not going to feed. In the meantime, they're trying to use unmodified animal milk, because in Vanivilas, I don't know what's happening. They are using unmodified animal milk in the meantime, because we don't use formulas at all. So the mother should be strictly taken care of. Many times what happens, the baby is in the NICU, nobody is telling her about the expression of breast milk. She goes for a breast and full breast engorgement and milk suppression. I just showed you a slide on feedback inhibitor of lactation. So this is what happens. Ensure that the mother expresses the breast milk every 3 hours. Sana was telling me they don't have an attendant to bring the milk from that ward. She can express it and throw it. I don't mind, but she should keep up the milk supply.
Thank you, madam. That was a good discussion. Madam, few more questions to Dr. Srinath regarding human milk banking. Sir, are you there? Hello? Hello, Srinath, sir?
Much here.
Yeah, can you hear me, sir?
I can hear you very well, yes.
Yeah. Sir, few more questions from residents. How long you are going to store a breast milk in a freezer and a regular compartment? They are asking.
See, in a fridge, you can only store up to 24 hours, okay? So as you can't keep more than 24 hours. But in the freezer, you can store up to 6 months. You have to, if you maintain the temperature minus 20 to minus 30.
Yeah. Few more questions, sir. Does pasteurization destroy the nutritive value of a milk, mother's milk?
So majority of the macronutrients are preserved. However, some of the micronutrients are lost. So if you ask me about carbohydrates and lipids, they are preserved, and most of the proteins also preserved. Only 18% of the proteins probably may get denatured, and other macronutrients are retained, and some of the micronutrients are destroyed during the process. But it is definitely not as good as the mother's own milk, but it is much better than any formula which doesn't contain these immunological properties.
Okay, thank you, sir. Sir, few more questions. Sir, what about your opinion regarding promoting human milk bank in the peripherals, not like Bangalore, peripheries of Karnataka?
It is very essential these days because a lot of NICUs are coming up in the peripheries, and a lot of babies are surviving now because more and more people are actually trained and they're expertised. Actually, they're opening up their own centers in the peripheries, and it's very, very important for us to concentrate on the peripheries and help them to come up with the milk bank in at least one in each district, which can actually cater to all the NICUs.
Sir, what is your opinion about private-public partnership in this, sir?
It is very much essential because, so when you need to look at the how with a minimum cost effectiveness, you can actually get a human milk bank running. if you look at us, actually our maintenance cost is very minimal because we only pay for two salaries. One is for the nurse, one is for the runner. And my services come completely free, and we do not have any other overheads. So we need to keep the cost minimum, and that's where we're able to give it to only at a cost rate for the hospitals. But if you have too many employed, then cost will go up. So we need to have a right partnership between public and private, and we need to minimize the number of personnel.
So what is the role of our NNF in this? If you are, what do you want to address regarding the
There's
NNF?
a huge role because a lot of NNF members have asked me. In fact, I have shared my presentation also. Some of the hospitals have even given the presentation also. A lot of donors are also coming up to donate milk. So donate money to set up the human milk bank. So NNF role is really very, very important. We can actually set up so we have a committee in place, and whoever wants to set up, we can actually lend all our help, and also we can identify and the donors who can actually come and donate. So definitely,
So
and we
one
need
more
to come up
question.
with a guide.
Yeah. Sir, regarding medical legal aspect, Devraj sir already discussed, sir. What are the precautions you are taking to get rid of all those issues? Like, are you taking
Actually,
some consent?
absolutely. We do not do anything without consent. We take a written consent, and everything clearly explained to them. And also, all these records are stored in our computers as well as in the record books. Okay, and very, very meticulous recording. Actually, I didn't include that in the presentation because it was already getting a little elaborative. So, but we have all the records of right from the day one, the donors records, the recipients record, which batch number recipient has received, and everything is completely saved. And each and every, even the batch when we do the pasteurization, the log, temperature log also recorded for each and every batch. So it is very meticulous. It's very, very
Sir,
important, as Dr. Devaraj said, Dr.
yeah.
Rajesh
Sir,
said.
how much it cost, a minimum cost to establish a small human milk bank in a peripheral setup? And what are the prerequisites, what are the legal things which we should take care before establishing the human milk bank? That is also one more question they have asked.
As I said, the breast milk analyzer is not a mandatory, it is optional. Actually, if you go with the imported steady feed pasteurizer, at least we are looking at anywhere at about 20 lakhs to set up a human milk bank. And basically, as Dr. Raichu said, we need to make sure that all these the consenting processes should be there, and also all the record keeping is very, very important. And as long as you have informed consent and keep the records and follow the process. Process should be meticulous because a lot of things involved in making sure that all these blood tests are done for the mothers, it are recorded, and also other cultures are done for the milk and they're recorded. So those needs to be really monitored.
Thank you, sir. You have answered all the questions from the resident and fellows who have joined here,
And
sir. Thank you,
one of
Asha
them asked,
madam.
why are you
Yeah,
not testing CMV? Sorry. One of them asked, why are we not testing
CM.
CMV? The reason
Testing
we are not
CM.
testing CMV is 100% destroyed during the pasteurization process. That is the reason none of the NICE guidelines or Ambana guidelines recommend doing CMV for these mothers.
Yeah, so that's fine, sir. So I think you have explained all the things, whatever questions they have asked, sir. Thanks, Asha madam, and thanks, Srinath, sir. That was a wonderful talk. And over to Prashant.
Yeah, thank you, all the speakers. We have our President NNF, Dr. Kodreshi sir, online. Sir, would you like to add few things, sir?
Yeah. Prashant. On behalf of Karnataka NNF, I am very much thankful for these Dr. Asha and Dr. Manikanti. Manikanti has done a wonderful job after the baby delivered, who needs really a natural breast milk. Even though in BC also, when in sisters also in wet nursing has been promoted, he has done a wonderful job of how to keep and how to storage, how to the delivery, and meticulously planned well also. I especially appreciate Dr. Asha madam giving the the first number importance for breast milk and even triplets and twins also. And they are very much thankful for these two speakers on behalf of Karnataka NNF on this series. Nice to hear, sir.
Yeah.
Thank you,
And,
Kotesh sir. Thank you, Prashant, for the
and
wonderful
one more
opportunity.
thing we would like to tell that NNF Karnataka has made 10 committees, which includes the lactation and which Asha ma'am and Dr. Srinath is in charge of that. So anybody who is interested in setting up human milk bank across Karnataka, NNF Karnataka are going to completely support in terms of giving all the legal advice and how to set up and how to raise funds, everything we are ready to do. You can contact us, you can mail it to us, or you can directly speak to us. We are going to help you and do our personal best what we can offer for you to set up at your place. As we said, we need one thing, that is the money. So if you are interested, we can all sit together. NNF Karnataka office and the committee is always there to help you people. So I would like to thank the legend, Dr. Asha Benakappa ma'am. Ma'am, thank you very much for accepting and speaking so beautifully about breastfeeding. And we are so fortunate that we are able to listen to you live. And I would like to thank Dr. Srinath Manikanti, a pioneer in Karnataka, to start Human Milk Bank, one of the pioneers. Thank you very much for your experience and taking us through the virtual tour of Human Milk Bank. And I would like to thank Dr. Shweta and Dr. Soumya for sharing their experience. And I would like to thank all the seniors, all the colleagues and friends who have joined and where we have learned and where we are sharing the knowledge. So this sharing has gone global. Thank you very much for making it happen. Let us catch up again on Tuesday. So Tuesday.
Dr. Prashant,
Yeah.
if you permit me, I would just answer one last question, which is very, very important.
Yeah.
Because Dr. Sidhu has asked me, do you pay the mothers? And what about the motivational aspects in terms of honorarium? I categorically said we never pay any mother, because once you start paying the mother, okay, it'll come into ethical issues. Okay, they're all purely voluntary. Okay.
Thank you. Thank you. I'm sure all the doubts are cleared. Thank you very much. Let us catch up. So the Tuesday, again, day after tomorrow, we have another beautiful session by Dr. Abhishek Patke and Dr. Manisha Bandarkar ma'am. So let us join again for the upcoming session. Thank you very much. Have a great day. Thank you. Have a great Sunday. Thank you. Thank you. Thank you.
Thank you so much. Thank you, Asha ma'am. It was wonderful sharing the stage with you. Thank you.